Welcome to part 3 of this lecture. Let's begin by discussing retreatment after failure of DAA therapy. With SVR rates greater than 95%, the need for retreatment is fortunately small. In patients who fail HIV therapy after a protease inhibitor and/or NS5A inhibitor containing regimen, the triple combination of sofosbuvir, velpatasvir and voxilavir is the preferred regimen. If this regimen is not available, retreatment strategies should include at least 2 active drug classes according to resistant testing results, with a preferential use of one drug with a high genetic barrier to resistance and with extended treatment durations and potentially addition of ribavirin. This table from the 2018 ERICS guidelines gives an overview of drug-drug interactions between DAAs and antiretroviral drugs. Those in blue have no interactions, while those in orange have a potential interaction and may require dose adjustment, while those in grey should not be co-administered. More detailed and up-to-date information about drug interactions and dosage adjustment can be found at hepdruginteractions.org. Acute hepatitis C infection is defined as the first 6 months of detectable HIV RNA in serum. Acute hepatitis C is most often asymptomatic, but suspicion of recent infection is often triggered by an increase in liver enzymes at routine blood testing. In addition to people who inject drugs, HIV-infected men who have sex with men are at increased risk of acquiring acute HIV infection. Several outbreaks of acute hepatitis C among HIV-infected MSM have been described in cities around the world. Here you see an algorithm for management of acute hepatitis C among HIV-infected persons. Less than a quarter of all people with acute infection will clear the HIV infection spontaneously. HIV RNA testing should be repeated 4 weeks after the first HIV RNA positive result. If the viral load has not decreased by at least 2 log by this time, the risk of chronic infection is close to 100%, and short-duration DAA therapy should therefore be considered. In persons where the viral load has decreased at least 2 log by week 4, the viral load should be repeated at week 12, and if it's positive at this time, DAA therapy should be considered. An SVR is considered a virologic cure. An SVR has been shown to reduce the risk of liver-related and all-cause mortality in both HIV monoinfected and co-infected persons. However, liver failure and hepatocellular carcinoma after SVR is well documented. As you can see in this graph, in a study of almost 600 HIV monoinfected patients with advanced fibrosis, ISHAC 4-6 at time of HIV treatment, the cumulative incidence rate of HCC after 10 years post-treatment was 5.1% for patients with SVR and 21% without SVR. The risk of liver failure after SVR is low after SVR, but can still occur after several years. More severe hepatic fibrosis, older age, and a history of severe alcohol use were risk factors for both HCC and liver failure. SVR is also associated with a decreased risk of diabetes mellitus. Some, but not all studies have also found an associations between SVR and a lower risk of cardiovascular disease and other non-liver related clinical events. It is well known that clearance of HIV RNA spontaneously or as a result of treatment does not prevent HIV reinfection after new exposure. Reinfection obviously negates the benefits of SVR. In the DAA era, observational data from the German GECKO cohort have shown that men who have sex with men, most of them co-infected with HIV, have a very high risk of becoming reinfected shortly after they have achieved an SVR. As seen in the upper panel, the incidence of reinfection was 14 per 100 person-years of follow-up among MSM, compared with only 1.8 per 100 person-years of follow-up among people with a history of injection drug use. A low risk of HIV reinfection was also seen among 199 people who inject drugs on opioid substitution therapy who received elbasvir and grasupavir in the COSTART Part A study and follow-up for 24 months. 10 were reinfected, with 7 developing chronic infection, yielding an overall incidence of 1.6 reinfections per 100 person-years of follow-up. As shown in the lower panel, the incidence depended on whether the participants reported injection drug use during follow-up. In addition to counseling all patients on risk of reinfection, it is recommended to test for HCV RNA or HCV coantigen in persons with high risk for HCV reinfection after SVR or spontaneous clearance at 6 monthly intervals. As mentioned earlier, persons with liver cirrhosis are still at risk of HSC and liver failure after SVR and should therefore be offered 6 monthly ultrasound for HSC as well as endoscopy for esophageal varices. Thank you for joining me for this lecture on hepatitis C and HIV.